Hello and welcome to Crisis Intervention Chapter 4. One of the things that we will talk about in Chapter 4 is Chapter 51. Pretty good thing for you to know about whether you're going to be a crisis intervention worker or not. If you are in social services and going to remain in Wisconsin, good thing to look through. Not only that, but each state has something like Chapter 51. We have something very similar in Illinois here. The verbiage is usually fairly close in terms of what the requirements are as it follows federal guidelines. So let's talk a little bit about suicide. Sounds like fun. Okay, so this is a combination of dangerous to self and others. We're talking about um, people who are having either difficulties with depression, um, general dangerousness to self or others, or psychotic decompensation. So, as we start, the text talks about Norman Fabreau. He's considered one of the founding members of what we call suicidology, which is the study of suicide, which is pretty fascinating sort of stuff when you look at the history of suicide. It's interesting, I think, culturally how we've treated it and also how other cultures treat it, because there are often a lot of things about legal and religious components that are an important aspect of the discussion around suicide. Um, and Farborough basically researched the fact that meds alone didn't seem to stop suicide or the self destructive behaviors that we would see in our clients. Some of the things that we know about suicide, it occurs in about 1 to 3 people per 10,000 per year. There are an estimated 8 to 25 suicide attempts for every death, and nearly half of those who attempt it do not seek treatment. So this is a pretty significant, serious issue, and this crosses cultures. What I mean by that, there are paths that lead people from different regions, backgrounds, faiths, values. Different paths that they take, but it can lead into the same direction. So it is something that um, hits everybody, regardless of socioeconomic status or not. At different rates, certainly, and different reasons, but everyone. According to the CDC in 2001, so it's a little bit old, it was the third leading cause of death for people between the ages of 10 and 34. Third leading cause of death between the ages of 10 and 34. It outnumbered homicides 5 to 3. When compared with the general population, the highest rates are typically seen among those who are single or divorced, have low levels of education, and are unemployed or disabled. And one of the things that we do know is that more people die from suicide than murder. I'm going to bypass this. I think I'll have the video itself in the site, but it's a nice discussion about treatable psychiatric disorders and interventions on the ground by one person, and it's a personal story, so take a look at it. So, 90% of people who die by suicide have a diagnosable and treatable psychiatric disorder at the time of their death. Most people with mental illness do not die by suicide. See how you can fit that into your thinking. Recent data puts yearly medical costs for suicide at nearly $100 million. Men are more likely to die by suicide than women, however, women attempt it more often. Additionally, Native American people are the most likely to die by suicide, followed by older white individuals. So, if we take a look at the suicide rate per 10,000 since 1993, you see a dip and then an increase. Later, you'll see it starts to dip down a little bit in terms of age, but we'll see. Per group, see there's a dip down, and then it goes back up to 85. It wasn't that long ago that it was 85 and over who had the highest suicide rate. Now we're seeing that more in the midlife range, having a higher suicide rate more recently. We do know that every 13 and a half minutes, someone in the U.S. dies by suicide. Let's talk a little bit about it by in terms of state. Wisconsin ranks 793. Um, Wait a minute, let me see this. Oh, okay. Out of the 50 states, Wisconsin ranks 27th. The number one state is, can you guess? Let me hear you say it out loud. You're wrong. It's Wyoming, number one. Isn't that interesting? Guess what is the last? Number 50. Number 50. Guess. Let me hear it out loud. New York. Can you believe it? Interesting, right? Think about why the differences would be that way. It's interesting. Although suicide affects all people, certain groups are more burdened than others. In Wisconsin, adults aged 45 to 54 experience the highest rates. 4 out of 5 people who die by suicide are male. Whites experience the highest suicide rates by race, followed by American Indians, Alaska Natives, Asian Pacific Islanders, and Black African Americans. Common circumstances related to suicide in Wisconsin have been identified. These are 50% of suicide descendants have at least one known mental health problem, and more than 40% are receiving mental health at the time of death. Personal crises, intimate partner problems, substance use problems, physical health issues, and job problems are the prominent determinants of suicide in Wisconsin. According to the CDC, suicide is in the top 5 causes of death for the ages 10 to 54. That was in 2013. The second leading cause of death for age 15 to 34. The third leading cause of death for 10 to 14-year-olds. And from ages 10 to 65, it beats homicide as the leading cause of death. We'll chart by race. So some of the symptoms and clues are things you probably may have heard of before, which you should include in your assessment as you're asking questions or interviewing the client or their family members, asking about what sort of things they're doing that might be tip-offs to potential suicide attempt. Other symptoms include clues, of course, along the mental health spectrum with agitated depression, psychotic behavior, being isolated, talking about the end, that sort of stuff, like obsessive talking about the end. When we're doing assessments, we determine risk level, and then the risk level is actually what determines the type of intervention, right? So low risk level is a person who might have ideation, they might have a plan but no means, or the plan is really not very viable. I've had adolescents, or like immature adolescents. I had one tell me that they were going to kill themselves by choking themselves with their own hands. Um, so obviously, this is somebody who has bad feelings about themselves, but their plan is not very sophisticated. So I'm not as concerned as I would be for someone that age who said that they had access to a gun, for example, or pills. Um, at the low range, we're talking about supportive approaches, a verbal no suicide contract. That's probably the only place I would do a verbal no suicide contract. I'm not a big fan of using those, although I know it's a tool in the field. My own personal concern is that it really holds no weight in court. So you put somebody on a no suicide contract, whether it's written or verbal, it doesn't really matter, because if they kill themselves, then you may be called into court to talk about what your interventions were. In terms of the middle risk level, this is a person who has ideation, plan, but and maybe means, but perhaps something can stop them. Um, like they seem to have maybe a family member, or there's some issue in particular that might be able to change them. Um, Again, in the text, they talk about a no suicide contract. Although, if I were to do anything along those lines at the middle range, I would make sure that there were plenty of family members who can provide supervision of the person before I go into talking about a no suicide contract, because I wouldn't want that person to be just me and them in the room with a piece of paper saying, okay, you're not going to do this, right? So in this case, you'd want to make sure there's increased contact, family supervision, take away the means if they have access to a gun, refer for medical evaluation, and there is voluntary hospitalization. They could sign themselves in when they're very depressed, and some people do. A lot of people aren't big fans of that because of the connotation that our society imposes on them, but it is something that can be very helpful. Think about psychiatric unit. Think about it like an ICU. Like if you had a serious medical condition that was nearly life threatening, you'd probably end up in an ICU or an ER, right? So think about it that way. We have this thing in the in the states about separating out mental health and physical health, and it doesn't do us any favors. In terms of the high risk level, you're talking about someone who's got an idea of suicide. They have plans. They have a means. It doesn't seem like there's anything can stop them. And I can tell you this, having worked with plenty of people in psychiatric hospitals, if there's someone who really has a determination to do something to themselves, it can be done regardless of psychiatric hospitalization or not. Psychiatric hospitalization, I think, greatly reduces the risk, but people have killed themselves in hospitals as well. Um, So one of the things I like to talk about when we're getting into the suicide business is talking a little bit about there's oftentimes a religious or moral connotation that goes along with that that interferes with people's ideas. And I think as a clinician, it's important to evaluate your own because imposing a judgment on someone who's in this state really is not helpful in any way, shape, or form. We also have something that's kind of unique called non suicidal self injury or self mutilating behavior, self destructive behavior. These are folks we're talking about cutting, maybe putting cigarettes out on their arms, things like that. So these are people who damage their own bodies. They may even feel depressed or talk about suicide, but they aren't necessarily going to commit suicide. That's not necessarily their intent, and that gets tricky because those are folks who do some frightening things and alarming things, and of course, clinicians concerned about both the safety of their client as well as legal implications will then move forward with hospitalization when it may not always be necessary. Sometimes, you know, I think when it's a shade of gray and you're not sure, I go more conservative than anything else. So I will try to have someone hospitalized if I am not convinced that there's something that can keep them going through the pain that they're going through. Uh, and that can interfere with your relationship with them. But at the same time, the number one thing you should always be thinking about with your clients, regardless of what's going on with them, is safety. All right, so NSSI and self mutilating behavior are not diagnoses, but you have to consider these sorts of things before calling it self injurious behavior. You have to think about what the difference is between their behavior and what suicide is, and you have to compare the assessment questions. If you think about we have a section that talks about, I think it's on page 96 and 97, that talks about self injurious behaviors, and then some on 87 88 that talks about suicide. If you look at the way those questions are set up and what they're trying to get at, they are different. There are differences, and I think as you're learning this stuff, doing a real good compare contrast of those sorts of questions may help you determine the difference between self injurious behavior versus suicidal intent. Some of these folks have what we call an impulsive disorders. They may have access to disorders. It used to be called access to, sorry. Borderline personality disorder or other personality disorder. So, in those instances, these are people dealing with intense internal pain and they don't know how to modulate their feelings or regulate their emotions. And so, to do that, they resort to maladaptive coping mechanisms like cutting. You can see substance use, other things that are more self destructive. And you can also see these things in folks who have intellectual disabilities, banging their head against the wall, scraping skin, biting themselves. And that itself is not suicide ideation either, but does not mean that they would avoid psychiatric hospitalization either. So, some of the interventions for those folks, make sure you try to create a safe, non threatening, and structured environment. CBT is very helpful, unless we're talking about, um, people who are more have more intellectual deficits, in which case you may go to more behavioral methods rather than the cognitive component. Psychodynamic psychotherapy can be helpful for people with a bit more insight, thinking about internal struggles, past experiences. Group therapy is very helpful, actually, because I think people find that they're not alone in the world and in having these feelings, and can get some support just out of that alone. And also, one of the main, or I say larger approach to treating folks with personality disorders is through what we call dialectical behavioral therapy. Marsha Linehan is the author. And as you move along in your studies, you may hear more about DBT, they call it. Very interesting. You have to invest a lot of time and effort into training before you can use DBT. It's pretty extensive. It's a combination of sort of like Middle Eastern meditation, CBT, behavioral approaches, psychodynamic approaches, with a lot of real strict boundaries. So, how do you manage a client who's a danger to others? First, you assess for risk, and I've got a list of the some of the risk factors. Oftentimes, homicide or danger to others is related to psychiatric disorders. You can see what we call auditory command hallucinations. Someone who's having a psychotic episode may hear voices telling them to do things. That's pretty important. If you hear that, it may be out of their hands, and psychiatric hospitalization may be necessary. It can be related to anger, poor impulse control, or substance use in particular. If you're seeing substance use and this is a person who's kind of impulsive, that's not a good sign. You have to look at risk factors with regards to where they come from, recent life events, that sort of stuff. When internal controls are not working for people, you need external controls, meaning if they cannot regulate their behavior and they may pose a risk to someone else, then you need to do what you can to keep them and other people safe. And that's where you can go straight into calling 911 because of concerns about danger to self or others. The other way that you can have someone psychiatrically hospitalized if they are so gravely disabled that they are unable to care for themselves. And there are some interesting movies and things out there. I kind of think of My Brother's Keeper. It's this movie, older movie, a documentary about these two probably intellectually disabled brothers who live together, and one of them seemed to be pretty unable to take care of themselves. It's just kind of interesting. Um, with a psychotic decompensation, you can see what looks like schizophrenia. Okay, delusions and hallucinations. These are folks who may not be able to take care of themselves. They may, like, for example, start cooking something and walk away from it and burn their house down. But that isn't exclusive to psychosis. That can be other things as well. So I don't want you to think that. Um, Consensus on lifetime risk of suicide was approximately 5%. Risk factors with strong association with later suicide included being young male with a high level of education, that's later in life. Illness related risk factors were important predictors with a number of prior suicide attempts, depressive symptoms, active hallucinations and delusions, and the presence of insight having strong evidential basis. Meaning, if you have someone who's psychotic and they're very aware of what's going on with themselves, it can be not so good for them in terms of how they feel about what they're going to do and what they may do. You may see a family history of suicide. If you ever look into Ernest Hemingway's family history and suicide, it's pretty fascinating. You can really see that there is a intergenerational trend towards suicide in his family, which means there's probably a mental health issue that's being passed down that may not be treated or being treated in a maladaptive way. A couple of stats on schizophrenia and suicide. After 10 years of people who were diagnosed with suicide, about a quarter of them completely recover, a quarter are much improved and pretty independent, a quarter are improved but require extensive support, 15% are hospitalized and unimproved, and 10% die by suicide mostly. After 30 years, these folks 25% completely recover, 35% are much improved and are relatively independent, 15% improved but require extensive support, 10% hospitalized and unimproved, and 15% die mostly by suicide. And that comes from a book. If you're going to stay in this field, this is a great book to have. It's called Surviving Schizophrenia. It's by E. Fuller Torrey. Um, it comes out with a new edition every year. So the last edition I picked up was in 2006. So I'm sure there's a newer one out there. But anyway, it is a great text to have outside of crisis intervention. It's a great text to have when working with families because it talks about everything related to schizophrenia. One of the things that we do in terms of assessing for cognitive functioning is we do what's called a Minty Mental Status Exam. Sometimes you'll see this in ERs. It's a quick way to evaluate cognition. And I just kind of wanted to show you this to give you a sense of how the questions are asked, and they're very structured. Think of this as like a pre-screen. It just gives you a heads up as to what might be going on. There are other evaluations out there when it comes to suicide. There are depression inventories and suicide inventories and risk inventories that are always very helpful. And I think if you become a practicing clinician, your agency might even have them. But it would be good if you were, like, for example, in private practice, to have one even, at the outset when you're evaluating someone if they come in with a complaint of depression or impulse control disorders. All right, well, that's our lecture for this chapter. Have a good one. Or maybe it's not. On my notes, it is. But this is the non-mini mental status exam. This is like what you would evaluate the formal assessment tool. So obviously, whenever someone comes in, you're looking at their attitude, how they're dressed, how they look, their behavior, their speech. Are they slurring their words? Are they talking quickly? What is their mood like? Are they able to connect their emotions with what's coming out of their mouth? Do they have insight, judgment? All right, that's it now.